Sir, shall we start, sir?
Yes, let's proceed.
Good evening, all. I'm Dr. Sujitra, PG Coordinator, Spice Road, Kerala chapter. We have another one more interesting case presentation session organized by the Spice Road, Kerala chapter. So, for this, we have an eminent moderator for the session, a person who don't need much introduction from our side, Dr. Vijay sir, Senior Consultant in Star Care Hospital, Calicut, and a person who is very well known among our community. And we have a presenter, Dr. Hirash Ameen, DNB resident at Department of Family Medicine, ASTER MIMS, CALICUT. So enjoy this session and make it useful. Welcome, sir. Welcome to the session.
Can I start?
Thank you for the kind introduction. Yeah, Hirash, let's start.
So good evening. I'm Dr. Hirash, DNB resident Family Medicine, ASTER MIMS, CALICUT. So today I'm going to case presentation. So presenting the 72-year-old lady from Tikkodi near Koilandi. Informant is patient and her daughter-in-law. She presented with complaints of breathlessness for 1 week and swelling of the feet for 1 week. So history of presenting illness, she is known to have heart disease for past 1.5 years. She usually developed dyspnea while performing ordinary activities like climbing stairs and walking uphill in wheelchair class 2. Currently, for past 1 week, she developed a worsening of the breathlessness in the form of symptoms even at rest in wheelchair class 4. So it was sudden in onset and progressive. She was unable to complete a full sentence due to breathlessness towards the end of the week. It aggravated by lying down, and it is relieved by sitting up or being propped up with 2 to 3 pillows. Breathlessness was associated with the fatigue and swelling of the both feet. It was not associated with chest pain, palpitation, giddiness, or abdominal distension. No history of fever, cough, wheezing, calf swelling, prolonged immobilization, long travel, reduced urine output, or altered bowel habit. She also denies history of recent cold, cough, excess salt intake, excess fluid intake, palpitation, drug default, or intake of painkillers. No history of weight loss, anorexia, evening rise of temperature, or long-standing cough. So past history, she is known to have type 2 diabetes mellitus for past 15 years.
Hirash, may I interrupt you there, please?
Okay, sir.
You did a very good account of the history, the presenting complaints. How did you take the history? What format did you follow while taking the history?
History.
Did you follow the classical format like name, age, gender, address, presenting complaints, passes, that kind of a thing?
Yeah.
Okay. So what we can do is, just for your information, this is the classical method of presentation, case presentation, which works in the exam. So just for information and for the information of all those who are listening right now, there are various patterns of taking a history and presenting a history also. So it's good that for the exam you can present this way, but there is another way of presenting the history purely from the patient's point of view. Okay. Now we are presenting from the doctor's point of view. There is one way of presenting it purely from the patient point of view. Okay. So for the all those who are listening, please look through how to take that history and how to present that history. Right. So let's proceed, Hirash. I'll come to this topic later on. For now, let's proceed.
So, coming to past history, she is known to have type 2 diabetes mellitus for past 15 years and is on oral anti-diabetic agents, oral anti-diabetic drugs, and she is compliant on it. Blood sugars are fairly controlled. Last HbA1c was 7.2. Hypertension for past 15 years and is on medication. Dyslipidemia for past 15 years and is on medication. Hypothyroidism for past 10 years and is on medication. She coronary heart disease, coronary heart disease underwent percutaneous intervention 1.5 years back, and she has exertional breathlessness for past 1.5 years, and there is an exacerbation of breathlessness requiring hospital admission 8 months back and 3 months back, which were managed conservatively. Then coming to personal history, sleep was disturbed due to illness and hospitalization. Then appetite was good. Bowel and bladder habits are regular. No addictions. Attained menopause at 50 years and only one child, 48-year-old son. Diet history, mixed diet. Protein intake is inadequate. She was advised to follow a low salt intake and a water restriction of 1.5 liter per day. And coming to family history, elder sister died due to cardiac illness. Elder brother also having coronary artery disease. Socioeconomic history, she is a homemaker, currently not doing any household activities due to her illness. And her education is 4th standard. House is Pakka house. House has 5 members, her son, daughter-in-law, 2 grandchildren. There is 2 earning members in the family, and her husband died 2 years back. And socioeconomic class is upper class according to modified Kupuswamy scale. So, coming to provisional diagnosis from history, it is a acute or chronic decompensated heart failure. It may be either it is due to underlying. It may be due to different DDs are underlying ischemic heart disease, valvular heart disease, cardiomyopathies, or arrhythmias.
Okay, Hirash, have you done with the history completely?
Yes, sir.
Okay. What are the drugs she is taking? You didn't mention that.
Drugs for diabetes, she's taking glycomet GP1 B 2 times a day. Then Torglip M 50/500 in the noon. Then for hypertension, there is isoleucine half BD, then Titor plus, then hypothyroidism. She's on thyronum 50 microgram. Then statin, atorvastatin 10 mg in the night for dyslipidemia. Then also taking eccospirin 75 mg in the night.
Okay. So, Hirash, in the history, do you think there was any particular triggering factor for her symptoms this time?
This time there were no triggering factors.
Okay. Suppose this now you
Maybe
mentioned
some
that
viral illness. Viral infection may be the trigger.
Okay, what are the usual causes in primary care in general practice that we see which trigger congestive cardiac failure? Top 3 common causes.
Infections, then excess water intake, excess salt intake, arrhythmias.
Okay, then uncontrolled conditions like hypothyroidism, hypertension, untreated
Hypertension.
conditions like underlying CKD, CLD, then drug related. These are the commonest. I asked for only top 3, but there are like 5 or 6 conditions which we have to specifically look for. Otherwise, we'll miss them. Okay, if you are suspecting a drug as a cause, if a patient walks into you with a CCF kind of a picture and you suspect a drug, what drugs would be the top 3 candidates for causing this scenario?
NSAIDs.
Okay, good guess. Yeah.
Then
She is hypertensive, hypothyroid, and having diabetes.
calcium channel blocker.
Okay, you have to specify when you say that. Okay, the most likely candidate would be amlodipine.
Amlodipine.
Which drug in diabetes used in diabetes can give this picture? It's only one. If anyone wants to comment, please comment. One drug which you should not miss in primary care in a patient presenting with this scenario. That's a very common presentation. It was very common till about 5 to 7 years back. Now it is less common. Yes, Dr. Bino has responded saying it is pioglitazone.
Yes.
So pioglitazone you have to always look for in the prescription. It might be hidden among the brand names as a combination drug, especially those who are taking diabetes medicines 10 years before from now. Okay. Then when you say that this person has got diabetes since 15 years or hypertension since 10 years, it's always a good practice to specify the year in which it was diagnosed. Like you may say diabetes since 2010, hypertension since say 2010. Specify each year for the condition, especially for diabetes. Now, why is that important? Okay, because if you look at your EMR records in the hospital, you will find that 10 years back also the patient said the same thing.
Okay, sir.
And we also wrote the same thing, diabetes since 10 years. That 10-year story, 5-year story doesn't tend to change.
Okay,
So
okay,
we
okay.
should, when we are seeing our patients in primary care, we should always specify the year.
Year.
So now we know that it is not 10 years, even though the patient, it is a very common thing in my in day-to-day practice. I'm sure all of those who are experienced will realize this, that 5 years later also patient comes back saying that sugar തുടങ്ങിയിട്ട് 5 വർഷമായിട്ടുണ്ട് എന്ന് പറഞ്ഞിട്ട്. But somewhere someone might have written diabetes since 2005. Okay, now that becomes important because most of the complications, they are screened depending on the duration of these diseases. Like once after diagnosis of diabetes, after 5 years, you have to start yearly ophthalmology screening or yearly albumin to creatinine ratio screening. Same thing about hypertension also. You have to do maybe an echo after 3 years, 5 years, sorry, and so on. So if the year is specified, it becomes very easy to track the progress when they come for follow-up every time. Okay, so when you write investigations also, for example, if this lady came to me 6 months back, I would probably write in my notes, echo in 2022, ejection fraction was 45. Okay, now why is echo important here?
To assess the worsening of the.
Okay, how do you screen
to
for a
assess the
person
current.
at risk for, how do you screen a person at risk for heart failure in primary care?
First, ask for symptoms of heart failure.
No big deal. Our main job is as a gatekeeper. As a primary care doctor, as a primary physician, you will be assessed, you will be judged by your patient on whether you are able to identify a risk early enough. not after the diagnosis is clear. So if this patient came to you, say 2 months back, what would you think of for doing that? She's got a history of CAD, she's got history of ischemic heart disease already. She's already a diagnosed case of what you are describing now. She's on fluid restriction, salt intake restriction, all done. Now you are afraid that she's going to go into failure soon, maybe in the next month or maybe the next week. Suppose you saw her 2 weeks back or 2 months back. What are the two investigations which you would look for? Or you would like to repeat maybe?
Echo,
Okay.
ECG.
Not ECG really. Echo is right. The other is NT-proBNP. N-terminal proBNP. So I think the cutoff is above 75 years of age. The cutoff is different. It's I think more than 25 and less than 25. Less than 25 is okay in all ages, but above 75, I think the cutoff is slightly different. That usually they mention the lab reports in the site. Okay, but NT-proBNP and echo are commonly clubbed as a screening tool. And now there are scoring systems also which are available to primary care practitioners, where you can actually stratify the risk of the patient going into heart failure in the near future. Okay. So, okay. You mentioned glycomet GP1 BD, Toglip MOD, isolazine, Ditor Plus. What is the approximate cost of these medicines for the patient at the end of the month? Meeting. Anyone
Metformin
wants
will
to?
be glycomet around 500 per month.
Anyone wants to venture a guess? Now, why is this important? Now, suppose you mentioned she's upper middle class family, right? Upper
Yes,
class as per Kutup scale. What if she was lower class or middle class?
because we have to prescribe according to the financial status of the patient.
Okay. Yeah.
Because
So yeah, many of these medicines are available at almost half the rates of these brands. Although I do prescribe all these brands, but they all depend on the affordability of the patient. This is very important. Also important because of compliance issues. People might not tell us that they are not compliant with the medicine. They will say they forgot, they ran out, no one was there to bring. Stories. But in many patients, in at least 20-30% of the patients, the issue is cost. We might think it is not costly, but for the patient, even if they are reasonably well off, the parents will be reluctant to make the children spend. Like anything over 2,000, 3,000 rupees of medications in the current era, for any family, please ask them about the cost and try to pull the cost down wherever you can. Okay, so atorvastatin and even Thyronorm, Glycomet, or this can be made less costlier if the patients demand it. Okay, right. So now in the history, you didn't mention about her quality of life. You touched upon it that she's not able to do housework. But in the care of the elderly, in Rakel, if you read, there is a chapter called as care of the elderly. In that, they have mentioned how to categorize them as per activities of daily living. So, what would be her category? Anyone wants to volunteer? Just the short forms will do. There are basic activities of daily living, intermediate activities of daily living, and advanced activities of daily living. Advanced activities is where activities are not much restricted. They are able to go out, they are able to socialize, not much of restriction. Intermediate is where they are dependent on other people for some things. Like they can brush their teeth, they can feed themselves, they can bath themselves, and they can walk with some support, but they're not completely dependent. And basic activities of daily living means for every basic activity also they need support. They can't do it by themselves. Okay, so this is one single word where you can give a lot of picture to a different doctor or you can communicate to the support staff that this patient is on basic activities of daily living support. Okay, which means that patient should be planned for home visit in this visit itself. They should be getting in touch with the home care team for regular visits if they need to. This is the visit when this should be discussed with the patient. Okay, depending on what category of daily living they are in. All right. Right. How is the sensorium?
Sensory.
Anything in the history where she mentioned sensorium?
Most of the answer was given by her bystander, her daughter-in-law.
Okay. Okay. What is ICE? ICE. Anyone who's listening is free to type in the comments. Okay, no problem. Hirash can copy paste the answers. No problem. ICE. Okay, ICE is something which is a very common term used in most of the Western exams and Western practices. There are ideas, concerns, and expectations. Yes, I think
Yes.
Bino has written it rightly. I'm sure
Yes,
Hirash has heard of this term.
Yeah,
Ideas,
sir.
concerns, and expectations.
She has multiple comorbidities, including some cardiac illness, and uh, that is why she developing this exacerbation of breathlessness, and she is worried about the illness, and she is anxious because her sister and husband died because of the cardiac arrest, and she feels lonely. Also, she feels lonely after her husband's death 2 years back. Then she also concerned that her hospitalization may become a burden for her family members, and she expects she will recover by the treatment. And
Okay. Okay, right. So did you screen her for anxiety? Okay. Did you screen her for depression? She's got a chronic disease, which means she's at high risk for depression in the elderly. Then acute exacerbation of any chronic disease can worsen the depression and trigger anxiety also. So did you ask her about depression? Okay, right, fine. So
already
please
she's
look into
worried.
all. Yeah, she's worried. That's true. Worry is different from anxiety. Worry is usually
Depression.
temporary. Anxiety is something more sinister. Okay, people feel anxious for no reason, but people usually feel worried for a reason. Okay.
Depression
So,
means low mood.
mhm.
Um,
What is the opening statement you asked to screen a patient for depression? One single line, which is common in most of our textbooks.
Anhedonia. The
അയ്യോ അതല്ല. Hirash, have you read any family medicine textbook so far?
vehicle.
അത് സ്റ്റാർട്ടിംഗ് തൊട്ട് വായിച്ചിട്ടില്ല. കാരണം സ്റ്റാർട്ടിംഗ് വായിച്ചിട്ടുണ്ടെങ്കിൽ ഇതൊക്കെ കവർ ചെയ്യും. You must have to look at the topics, individual topics. So to all the listeners who are in training right now, one important tip here. Please read our family medicine textbooks, whichever you are reading, from cover to cover. Okay, if you only focus on the topics, you will get good knowledge, but you are losing on the soul of family medicine, which is there in the first few pages. Including that Park's textbook of preventive and social medicine, those initial pages which we tend to skip are very, very important. Because that is where all the soul of family medicine and that subject will lie, whichever textbook you are reading. Okay. അപ്പോൾ പ്രീഫേസ് ആയിക്കോട്ടെ, ഫോർവേഡ് ആയിക്കോട്ടെ, ഇനീഷ്യൽ ചാപ്റ്റേഴ്സ് ഉണ്ടല്ലോ, the concept of family medicine, primary care, screening, common questions, common presentations, symptoms, ഇതൊക്കെ റേക്കല്ലോ തന്നിട്ടുണ്ട്. Please read through them. Okay. And from now on, whenever you see a patient with who is elderly, who is facing elderly issues, not an age cutoff, but functional cutoff, let's say, you should always incorporate the points which are mentioned in the care of the elderly chapter from Rakel or from any textbook which you are following. That is where you'll get how to assess the functional status of the person. Okay, you need not have all the scoring systems by hearted in your mind. Like for depression, there is a PHQ-9. അതാണ് commonest questionnaire depression. Patient health questionnaire 9 version. അതിൽ നമ്മൾ simple words ൽ ചോദിക്കുമ്പോൾ the opening statement is, do you feel down, depressed and hopeless? Down, depressed and or hopeless. That is what we which we ask first to get the patient to try and open up. If they answer yes to any of these questions, then you take out the questionnaire. It is there on mobiles, desktops. For experienced people, it will be there in the mind. If they answer yes to most of the questions in the questionnaire, don't go by the cutoff again, like 7 out of 10 is depression, 6 out of 10 is moderate depression. No, don't go by that, because you can't really cut off. What is moderate depression felt by the patient today will be severe depression tomorrow. It doesn't need much time. Yes or no, that you should know. That is important. Secondly, if it is present, then whether it needs pharmacotherapy or just counseling, that also you should know. Okay. So, isn't it surprising that this patient has been chronically diseased and she's anxious? And maybe you are the first person to ask her about these concepts. This is what a primary care person, the gap will be filled in the care. Okay, everyone is doing their work well, extremely well, but these chunks is what we have to identify and plug in the patient's care. Okay, so in the last 10-15 minutes, what all we have understood? One thing is, when patients come with the history, always look at iatrogenic or pharmacogenic causes. Drugs. We'll look at everything, but we'll forget drugs. One. Second is, they came with a problem. Could this problem have been identified and screened for in the previous visit? Whenever it was, like 2 months back or 6 months back. That is another question which we always have to ask in any patient present with an acute disease with a chronic background. Third question is, will this patient need continuous home-based support or home visits by a medical team? Is this hospitalization or this OP visit the right time to discuss it with them? That is, if you have a palliative care support or a comfort care support in your area. Okay, so I have patients for whom my staff goes at home, sees them, and they send me updates on a regular basis. Okay, but the discussion happens in the OP because I don't do home visits anymore personally, but my team does it for me. And the next one is, always screen chronically ill patients, whether it be diabetes or anything like this. Always screen them for anxiety and depression. Okay, because they might not want to hurt the children by saying that I'm alone at home and I feel alone at home. I don't feel care for anything. But there are other ways to find out whether they're anxious or depressed when they're at home and address the issue. Okay, right, fine. So, why is anxiety screening important in this patient? Simple reason.
It
Very
can
simple
aggravate the disease
Yeah, it can aggravate the symptoms.
symptoms.
So if she has anxiety, she's going to have tachypnea. That tachypnea is going to worsen the symptoms of the underlying congestive cardiac failure. That might lead to unnecessary medications, oxygenation, and all those things. Where all it would be needed would be simple counseling or an anxiolytic. Isn't it? Okay. So you said that her sleep has been disturbed over the last few days, isn't it?
2 days.
How would you improve that for this lady? She presented to the hospital. She has been having disturbed sleep over quite some time. How would you help her improve or get better sleep within reasonable and safe limits? How was she sleeping before she came to the hospital in the last few weeks or months?
Sleep was fine.
No. That is not what I'm asking for. How was she sleep? What was her sleeping posture at home? Usually, before she had this
I
acute hypertension.
usually sleep with one pillow.
Okay. Has she been educated about sleeping positions with a previous background?
No.
Okay, that should have been done. So one pillow is not enough. One pillow is hardly 4 to 5 inches. How much should be the elevation? Ideally, what is the purpose of elevation? Elevating the head end. If the examination side you would have said JVP കൂടാതിരിക്കാൻ JVP കൂടാതിരിക്കാൻ. From the patient's point of view or from the physiological or pathological point of view, what is the purpose of elevating the head end?
Decrease the venous
decrease of venous ഒന്ന് വായിച്ചോളൂ കേട്ടോ. ഓക്കെ, ദ പാത്തോഫിസിയോളജി ഓഫ് CCF ഒന്ന് വായിച്ചോളൂ. ഇത് അറിഞ്ഞിരിക്കാൻ നല്ലതാണ്. ബേസിക്സ് അറിഞ്ഞാൽ മതി. യു ഡോണ്ട് നീഡ് ടു ഗോ ഇൻ ടു ദ nitty-gritty very fine details, but you should know the basic physics behind it. That will explain a lot of other symptoms also. Okay, fine. Right. So, yeah. I think we have done quite a lot of questioning with the history part of it. Okay, Hirash, let's move to the examination part.
So she was examined on the day 4 of the fourth day after admission. She was initially in the ICU for 1 day, managed with Lasix, nitroglycerin, and white pack. Then she was shifted to room side. Then was examined on day 4 of the illness. Day 4 of the hospitalization. Then on general examination, patient lying supine, conscious oriented, moderately built and nourished. Height was 156 centimeter. Weight was 55 kilogram. BMI was 22.6 kilogram per meter square. Then no pallor, icterus, cyanosis, clubbing, lymphadenopathy or lymphadenopathy. There was mild pedal edema. Then skin and hair normal. No thyroid swelling, clinically euthyroid. No signs of chronic liver disease. Vital examination, pulse rate was 64 per minute, normal rhythm, regular rhythm, normal volume, and character, no radiofemoral delay. All peripheral pulses were palpable. Then BP was 130/80 millimeters of mercury. Respiratory rate was 16 per minute, thoraco-abdominal. Temperature was normal. Saturation was 96% in room air. JVP was raised 4 centimeter above the suprasternal notch. Then cardiovascular system examination. On inspection, shape of recording is normal. Apex beat is not visible. No scars. No dilated veins or visible pulsations. On palpation, apex beat felt 1 centimeter medial to midclavicular line in left fifth intercostal space. No thrill, no palpable P2, no left parasternal heave, no epigastric pulsations. On percussion, right heart border corresponds to right sternal border. Then left heart border corresponds to apex beat in left fifth intercostal space, 1 centimeter medial to midclavicular line. On auscultation, S1 S2 was here. There was an ejection systolic murmur, low pitched 3/6 gauge, heard and burst heard in the aortic area, which radiating to carotid. Then which was increasing on Valsalva and standing. Then respiratory system examination, upper respiratory tract visible part was normal. Then lower respiratory tract on inspection, trachea appears to be central. Shape of chest is bilaterally symmetrical. Movement of chest wall bilaterally symmetrical. No visible pulsation, scar sinus or dilated veins. On palpation, trachea in midline, chest expansion 4 centimeter, bilaterally equal. Then chest movements bilaterally symmetrical. No local rise in temperature or tenderness. Vocal fermitus normal and equal on both sides. Percussion normal, resonant, not heard all over the length fields. Upper border of liver dullness felt at fifth right intercostal space in the midclavicular line. Then on auscultation, normal vesicular breath sounds with bilateral fine crepitations was auscultated, and the vocal resonance was normal. On gastrointestinal system examination, shape of abdomen normal, all quadrants move equally with respiration. Umbilicus central and inverted, no dilated veins, scar sinuses. On palpation, soft, non-tender. Percussion, all quadrants are resonant. Liver span is 12 centimeter. Central nervous system examination, higher mental functions normal, cranial nerves normal, motor system normal, sensory system normal, cerebellar signs normal, skull and spine normal, no signs of meningeal irritation. So, summary: a 72-year-old lady known to have type 2 diabetes mellitus, hypertension, dyslipidemia, hypothyroidism, coronary heart disease with status post percutaneous intervention, then heart failure with NVHA grade 2 on regular medication, diet with nutrition deficiencies, now present with complaints of exacerbation of breathlessness into grade 4 NVHA for 1 week. On examination, there is pedal edema, elevated JVP, low pitched ejection systolic murmur of 3/6 lead, burst in the aortic area, which increase on standing on Valsalva. Then there was fine basal crepitations. So diagnosis: acute and chronic decompensated heart failure with acute pulmonary edema due to underlying cardiomyopathy, most probably hypertrophic cardiomyopathy and ischemic heart disease, and also diabetes, type 2 diabetes, systemic hypertension, dyslipidemia, and hypothyroidism.
Okay, Hirash. Okay. So suppose this patient comes in primary care to you in a smaller clinic. What are the signs, the points in the history and the physical examination which will help you differentiate between left heart failure and right heart failure?
In left heart failure, there will be orthopnea, dyspnea exertion, orthopnea, PND will be the. Then in right heart failure, usually present with the volume overload, present with the elevated JVP, pedal edema, dendropatomegaly, like that.
Okay. 2 points which we tend to miss, 2 simple points is in right heart failure, there will be usually loss of appetite. Okay, I think the reason is because of pooling of blood in the digestive system. One. Second would be in right heart failure, weight gain. Okay, edema might be there, it might be subtle, it might be pre-existing also, because such people, especially with thyroid disorders like in this patient, they might be having pedal edema pre-existing, but an unexplained weight gain over the last few weeks might be a subtle indicator of right-sided heart failure, impending right-sided heart failure. So yeah, so these are the points. So it's better to differentiate between them because the management is also different slightly. Now you mentioned in the echocardiogram previously that her heart failure was like her ejection fraction was how much? 40, 45.
Ejection fraction was 55.
55. Okay, so that is heart failure with preserved ejection fraction.
Preserved ejection fraction.
Preserved ejection fraction. Okay, right. Right. Then in the examination, you just mentioned that her apex beat was 1 centimeter medial to the midclavicular line.
Sir.
Why the medial shift?
Normal.
Maybe normal, but in this patient, what would you expect? You said cardiomyopathy is suspected. Why is the clinical finding not in expected lines with the clinical picture?
It's
Okay,
normal.
fine.
No, cardiomegaly was no cardiomegaly was
You said
on
1
examination.
centimeter medial to the midclavicular line, right?
Okay, so
What is the normal apex beat position?
1.25 centimeter medial to midclavicular.
No, count down. Okay, fine. Let's proceed with the next section. You said about the diagnosis, right? So how would you manage this patient in primary care, for example? Hospital treatment or dedicated, if the patient came to you in primary care with the same set of symptoms and you want to refer the patient to the hospital, which is about 2 hours away, and you want to keep the patient safe, what will you do?
So initially, I will start oxygen. Then
Okay.
oxygen. Then if a patient is very symptomatic, if the BP is okay, then if not so low, we can give Laxix 40 mg.
What is not so low?
Less than.
Yeah, see here again the clinical picture has to be taken into consideration. Usually up to 100/60, we can give diuretic. One shot of diuretic should be okay. Okay, but you have to monitor the urine output also. Oxygen, diuretic, then
keep the patient in proper position. Then we have to refer to a higher center.
okay, fine. Yeah, it's written. Yeah, Dr. Veena has mentioned this non-invasive ventilation. Fine, that's a good option. Yeah. So you might have to, if you have BiPAP facility in your primary care clinic, some of them have it nowadays. If you have such a facility, that also can be considered if the saturation is dropping, especially if there is tachypnea.
Okay.
Right. So suppose now the patient is stable. What are the points you would like to cover after having heard our first half of the discussion? How will you counsel the family? What all gaps in the care would you like to fill from the as a primary care doctor, as their family physician? Now you know all the answers. You just have to enumerate what all gaps you have to fill.
Before referring this patient.
No, now you have seen her today when she's just recovered from her illness. Her edema is reduced, her saturation is stable.
Okay, sir.
Now able to talk properly, coherently, etc. What are the gaps you have identified in the first half of our discussion, which you would like to modify in her ongoing care?
Correct the sleep correction.
Okay, how will you correct the
Anxiety
sleep?
correction.
What would you like to
Assess
give
that. You have to
Dr. Minath, correct. Anxiety, yeah.
use pillows.
Anxiety, we are discussing anxiety here.
Anxiety
Maybe even
correction.
depression.
For that we can add tricyclic antidepressants.
Tricyclic song.
Tricyclic
Are they the
antidepressants
first
or
choice?
SSRIs can be given.
For example?
Escitalopram.
SNRIs usually would come. The drug of choice in most cases. Suppose a patient comes to you with depression. If you are not sure what category to start and what drug to start, usually one of the first names that comes to mind is sertraline. Okay, pregnancy ആയിക്കോട്ടെ അല്ലെങ്കിൽ heart failure ആയിക്കോട്ടെ chronic disease ആയിക്കോട്ടെ, in most of the conditions it is safe. Then comes acetalopram. Okay, അത് ആ ഒരു ഓർഡർ ഒന്ന് കയ്യിൽ വെക്കാൻ നല്ലതാണ്. Suppose there's another patient for whom you want to be more careful that you don't want to give her sleep. You don't want to make her sedated. Then what is the drug which comes to your mind? Any one or two. Let's put it other way. Any anxiety drug or any antidepressant which has got disturbed sleep or reduced sleep as a side effect. Yes, Dr. Shivani, you are right. Fluoxetine. Fluoxetine can reduce sleep in some patients. That is why sometimes it is given in the morning also. It's in the morning. Okay. So as a habit, we tend to put all antidepressants and antipsychotic, anti-anxiety drugs in the evening, but there are some which you can give in the morning also. Suppose you want to make the patient feel more alert, then what is the drug you would think of giving? Warfarin is costly, correct? That's true. So here what happens is we tend to train under some departments, for example, psychiatry for 1 month. Isn't it? For 3 years training, we are only spending 1 month in psychiatry, and in whatever time we get in that posting, we try to learn as much as possible. Psychiatry posting is one of the most underestimated important postings in our entire family medicine training, I would say. Okay, because a large majority of our patients in a stable primary care practice or general practice or family medicine practice will be having psychological or psychiatric disturbances. Okay, and so you should be familiar with which drug is to be opted for which kind of individual, not which kind of condition. Okay, anxiety, depression, anyone can give an Exito or whatever you want. But suppose the patient specifically says, I want something to make me alert. Now you are fumbling for an answer. So psychiatry posting, 1 month, you pay complete attention and ask them why they are choosing this drug over the other drug. Okay, one other complicated prescriptions, you don't bother. Like if they are having, say, bipolar disorders and they are having 3-4 drugs running in a prescription, okay, if out of interest, you can ask. But if the patient is only on 1 or 2 drugs and the drug has been modified or changed, always try to make an attempt to identify why the psychiatrist did that change. Is it to make the patient gain weight or reduce weight? Is it to increase sleep or reduce sleep? Is it to protect the heart, protect the liver? Is it to shorten the duration of action of an antidepressant? Suppose you want an antidepressant which you can take only on SOS basis. Do you have something in your hand? There is something actually. But do you give it? So we tend to follow the norm, which is being practiced everywhere. But if you actually read the theory and the books, you will find more drugs which you can add to your armory, which you can use or bring it out only when it is needed. For example, in this case, bupropion also would be a choice. Okay. What is the commonly known indication of bupropion now? Oxford Handbook of General Practice of answer. Okay, yes, Dr. Shivani, Dr. Anath, you are right. Veena, Dashini, everyone is right. Okay, it is the drug of choice as per many books for smoking cessation. Okay, just out of interest, what is the other drug of choice for smoking cessation? Written in the books, which we hardly see in practice because of one particular issue. Vanilla vaccine. Okay, I think you're right. Right. The issues are availability and very high cost. That is why we tend to stick to bupropion. Okay. All right. I am bupropion details in the book. Okay. Hirash, what else would you counsel the patient for? What is the next gap you would fill? Anxiety, taken care of. Depression, yes, with sertraline, you can take care of that also. Escitalopram, okay, you can choose that also. If a patient is sleepy, wants to feel more alert, maybe fluoxetine, duloxetine, modafinil, fine. Bupropion also, fine. The gap out plug in
Counsel about the triggering factors. Counseling.
triggering factors. Like for example, yeah, what are the counselings you will give? What are the triggering factors?
Excess water intake, excess salt.
Yeah, I think good points are coming up. Someone mentioned diet, someone mentioned anemia right now. Drug default, very
Anemia
important.
correction,
She's
and controlling the comorbidities.
Okay. So how, okay, so now that you mentioned anemia, suppose her HB is 10 now. How would you proceed for this patient? And mild to moderate anemia. What would be the cause of anemia and how would you proceed? By the way, do you know this patient's HP? The real HB value?
11.4.
11.4. Okay, right. So someone is, Dr. Anath has mentioned is hemodilution, correct. So what is the natural response we should have? In case of doubt, you can always go for the iron studies. If the patient is affording, go for iron studies. Okay. If not so affording, then maybe you can look for the retic count. Okay, that can also indicate iron deficiency in some cases. Okay, since she doesn't have CKD and all, we don't need to go about erythropoietin and all those stuff. Okay, most probably she's on dietary restriction. She might be having iron deficient diet, and that might cause iron deficiency anemia in these kind of patients who are on severe dietary and fluid restriction. Okay, right. What else? How would you approach the topic with the patient and the family about home-based care? Sensitive topic. Because the moment we say home-based care, they think it is palliative care. Any patient വിട്ട് കളയാം. ഏതാണ്ട് സമയമായി. In the early stages of your career and your practice, when you know the concept and you try to apply it, you can burn your fingers with the family. How would you cautiously approach it? Tactfully, rather. Where is this patient from? This lady from? And the ever?
Koilandi.
Koilandi. Okay. Okay. Anyone wants to give a guess? What are the good opening statements to pass with the patient to start the topic, to get the topic going? Can we say straight away ask നിങ്ങളുടെ വീടിനടുത്ത് പാലിയേറ്റീവ് കെയർ സെന്റേഴ്സ് ഉണ്ടോ?
Okay.
അല്ല അങ്ങനെ ചോദിക്കാൻ പറ്റുമോ?
Mm.
That is a beginner's mistake. That question is a beginner's mistake. Even don't tell that even to a cancer patient first. It should be approached like somewhat like Breaking Bad news. Okay, but not as bad. But this is how. So what you can do is always keep this in mind. If you're practicing in a hospital like I do now, if the patient is coming from a far off area, it's always a good practice. Exactly. Dr. Dakshani has written correctly. No need to travel this far in case home care is available. But we approach the topic. I'll just give you the flowchart of it, a rough flowchart of it. When the patient is conscious, oriented, etc., and the most common bystander who comes with that person is there, that time you raise this topic. Okay, keep in mind that in hospital, if you counsel patients about all these things, the bystanders might change day to day. It might not be the same bystander. Next day, some other bystander will come. There will have been some communication gap between what you told and what the third bystander hears. Okay? So at least have 2 or 3 bystanders ideally, preferably those who are with the patient most of the time. Catch hold of them in front of the patient and raise this topic of home-based care. So how you should ask is this: you have been having this problem quite frequently, okay, and it's likely that you can have triggers again. You might have an infection, you might have breathing difficulty in the middle of the night. Okay, for that purpose, it's always good to have one doctor or one medical care team in your vicinity who knows about your background and status. Adinayittu, you get into touch with a local GP. Okay, so here they will usually say, okay, yes, this makes sense. Once this is done, then you can say, better than that, if there are people in your vicinity who can give her a home visit at least once a month or once every 2 months, that would be great. Okay, usually in Kerala, people are aware of palliative care, and some bystander will ask you, Doctor, ഞങ്ങളുടെ വീടിൻ്റെ അടുത്ത് പാലിയേറ്റീവ് കെയറിൻ്റെ ആൾക്കാർ വരാറുണ്ട്, അവരോട് ചോദിച്ചാൽ മതിയോ? So here, you don't have to convince them. They will ask you the question. 5 out of 10 times this approach works. Okay, because they are also looking at someone to come at home and give the personal look. Now you mentioned this lady is at home. Her son is working. 2 people working, earning members in the family, right? They are out of home
Yes.
most of the time, and they will also have this
They are in
anxiety
abroad.
because yeah, it is not uncommon for cardiologists to say review after 6 months. So what happens in the intervening 6 months? Whose responsibility is the patient? It should be the primary care doctors. So people ask us, no, what is your area? What is your niche area? What do you add to specialist care nowadays? This is what we add. People can't travel large distances every 6 months and wait every 6 months. There has to be a GP or a medical care team in the locality which provides home care. Right now, across Kerala, in most of the places, it's a palliative care team. But now there are clinics and small hospitals who also do that. So always tell the patient or the bystander to get in touch with the local people. Keep a clear copy of the discharge summary or the current medicines always in the mobiles of these people, these carers, so that whenever they go to the nearest center, they don't have to fumble for the documents. They should know exactly at least what diagnosis it is and what medicines the patient is taking. That makes treatment decision making much easier for the local care team in case of an emergency. Okay, this counseling is a must by every primary care doctor to every patient who is in chronic care, especially those who are not having enough family members to take care of them at home. Okay, okay. So, and again, an open question to the audience. Something else which we should always think about for people, especially if they're affording and having a chronic disease like this, or a combination of diseases like this. From the preventive point of view, Hirash mentioned that there are some triggers for CCF like this. What is that particular aspect which we'll think of, especially when the patient is stable? Exactly, Dr. Salima, you have mentioned right, vaccinations. Yes, Hirash, what are the vaccines you will suggest?
Influenza vaccine, the pneumococcal vaccine.
Okay, when do you give influenza vaccine?
Yearly influenza vaccine.
Yearly. What time of the year? Yeah, March prior to monsoons. Both are right answers. Something slightly better. Can you modify that? March is correct actually. Better before monsoon is also fine. September to March is also correct answer. Why are all these answers correct? By chance, these answers are correct individually. Why are they correct? Because strains keep on changing. Okay, new strains, yeah. So always keep in touch with your pharmacy and just ask, when did the last strain arrive? Okay, if it is within the last 4 months or 6 months and so on, that's okay. But usually I tell my patients to wait, let the next batch of vaccines come, that you take. That visit might be 2 months or 3 months from now. That is how I usually follow because these times are not specific. We say February, March, we say onset of monsoons, we say onset of winters, depending on the season. But usually I tell my patients to wait for the next batch, cross-check with the pharmacy. Like last time they told me the next batch will come in February. So that is when I would prefer because then they will get the latest rates. Okay. So as we don't need to remember all the numbers and details. We just need to know what is latest and that will be the most protective, likely protection offered. Okay. Coming to the pneumococcal vaccine, how do you give it? What is the frequency and what are the vaccines? Okay, anyone wants to venture an answer?
Conjugate vaccines.
Yeah. Yeah. What are the commonly available 2 variants of pneumococcal vaccine? And what does the guideline say? How should you give it? Yeah, 13, correct. Most of them are answering it right.
PC 20.
Commonly given so far was 13, and the next dose after 1 year is 23. Okay, the first dose is 13, the next dose is 23, which is a booster dose and it covers 10 additional strains. Now, what is the update in PCV? Now
Single dose
PCV
vaccines.
20. PCV 20 single dose is what you should give. Okay, single dose is what you should give. What is the cost of 13 and 20 and 23 approximately? Okay, so guidelines are there for everything, and we are supposed to give pneumococcal vaccine to almost all elderly people, especially with any kind of chronic condition like diabetes, COPD, asthma, heart conditions like this, chronic heart conditions like this, liver disorders, etc. But why don't we do it in why isn't PCV vaccine so commonly given? It's a cost barrier. Not everyone is able to afford it. That is the main problem. Okay, so around 2,000 rupees to 4,000 rupees it costs. The PCV 20 is around 4,500, 5,000 rupees almost. Okay, so cost always keep some idea in mind. Approximate cost you should always have in mind. Depending on that, you offer the patient. Okay, but offer the patient in all cases. Whether they want to take or not is a different story. And always document that you have discussed about vaccines, if you have discussed about. You don't want a patient coming and saying that doctor on the culturally pneumococcal. Okay, so if you have discussed it, always try to document it. Okay. Right. What else? If anyone else has to add anything to our discussion, now please unmute and we will discuss that. Any suggestions, points, queries, anything which important which we might have missed? Okay, it seems there are not many questions right now. So Hirash, you have any follow-up questions about this, about today's session?
Can we manage if the mild pulmonary edema can we manage without echo with Lasix if patient improve? Can we manage it like that?
In a resource deficient setting, yes, definitely, yes, you can manage and you have to manage. Even when I was working in Kinasheri Ikra, there are hospitals nearby. But there have been some occasions where the patient and the bystanders very clearly say, we can't take this person to hospital. You have to treat it here. Please do something. We documented, suggested echo, suggested referral, not willing to shift, not willing to admit, etc. And then we give Lasix. If you have a reasonable reason for giving such medicines in resource deficient settings, document this is the wish of the patient or the carer and proceed with what you feel is clinically correct. Okay, no one is going to penalize you even in real life if you give a 100 by 60 BP patient in a resource deficient setup whom you suspect something as serious as impending cardiac failure, 40 mg of Lasix. 110 ഒക്കെ ആണെങ്കിൽ പിന്നെയും കൊടുത്തോ 80 mg കൊടുത്തോ കുഴപ്പമില്ല. But you should have clear justification for that. And that justification should be written. Okay, Dr. Dakshayani has asked how to address polypharmacy in the elderly. Okay, you are asking the wrong person because my prescription sometimes have 11, 12, 13 medicines, sometimes. Now, that's a challenge I face in my practice also because patients come many times and they tell me, Doctor, now we have not seen this doctor for some time, that doctor for some time. We can't go there, etc., etc. Can you put all the medicines in one prescription and give me? So I oblige. So there are 3 medicines for diabetes from my side, maybe one antidepressant, one for neuropathy or something like that. And there will be 2 medicines from cardiology, 2 from orthopedics, something like that. So that is actually a very good chance for us to take charge of the patient's overall care actually. Because from that point onwards, the patient will have 1 or maximum 2 prescriptions, like many of my chronic patients do. Okay. First of all, you combine all those medicines and look for medicines which are not of utmost need. Most common example, multiple vitamin tablets. One from the ophthalmologist for retinopathy, one from the orthopedician for bone health, zinc and magnesium and all those things. One from my side will also be there, and one from the neighbor or watchman or milkman or whoever will give some other supplement saying that it's good for diabetes and hypertension. Knock off all the vitamin supplements, which are not of utmost necessity. If the person is on calcium supplement or needs a calcium supplement, go for something like calcium citrate maleate, which does not have much of drug interactions, has low risk of kidney stones, has less chance of dyspepsia. Okay, and is okay to use with antacids also. If we are giving calcium carbonate, stop that prescription in a polypharmacy prescription. If at all you have to give calcium citrate maleate. Okay, so that is one point. So there you can usually knock off 1 or 2 medicines. Then look for medicines which can interact with each other. Right? For example, metformin taken with iron tablets. Okay, iron tablet, preferably give it alone, maybe after a mid-morning snack or mid-afternoon snack. It will not reduce the number of drugs from your prescription, but it will reduce the potential interaction among the drugs. It will also reduce dyspepsia if you give iron tablet alone, if the patient is on iron tablet. Same thing, to be taken care of when giving calcium tablet also. Try to give it alone if possible, and never give iron and calcium together at the same time. That also we sometimes see, especially in gynec prescriptions. Elderly lady having some PV bleed, like perimenopausal kind of a situation. Some anemia might be there, already taking calcium supplements from the orthopedic side. And both iron and calcium they take together and they'll end up with dyspepsia. Then we add an antacid. That antacid worsens the dyspepsia because of calcium not being absorbed. Okay, and until someone identifies this overlap in the prescription or overlap in the drug, the patient will go on doing up till an endoscopy and think that now my stomach is like this only because of all these medicines. Patient is correct actually. It's because of the medicines. So here you can put a distance between the timing of the drugs. Keep a gap in the timing of the drugs. That you can do. Then one thing you can do is if the patient is on high doses of glimepiride, for example. Glimepiride usually above 4 mg for Asian pancreas, it's not effective. That is a common expert consensus. This is not what I'm telling. Expert consensus says so because of pancreas, the islet cells, beta cells are saturated in 4 mg. Beyond that, if the dose is there, then it's just a kind of a useless dose. Although the textbooks say 8 mg. Even now, we see some prescriptions where patient is on glimepiride 6 mg, 8 mg per day. Okay, reduce that. Okay, if the patient is on multiple oral anti-diabetic drugs, like he is on gliptin, full dose of metformin, full gliflozin also, insulin also, especially the patient is on insulin. In most of the cases, you can reduce the dose of glimepiride from 4 mg to 2 mg. Because already the pancreas are fired. The patient is on insulin. Especially the patients who are on a moderate to high dose of insulin, like 20, 30 units of insulin per day and above. You can, most of the cases, you can reduce the dose of glimepiride from 4 mg to 2 mg. Okay. Then another common prescription polypharmacy condition which we keep on seeing, getting like carried on for years together is this dual antiplatelets. In many conditions, you can stop one antiplatelet, reduce the dose of antiplatelet, or stop one antiplatelet after 1 year or 2 years. So depending on the patient's history, if the patient is not reviewed with the cardiologist, take the call on your behalf, on your own. There's nothing which stops you. Patient had a MI 3 years back, has been on aspirin 150, clopidogrel 150, clopidogrel 150. When they come to you for a follow-up, don't be afraid to reduce that one antiplatelet. Okay, reduce at least one, or reduce the dose of both of them to 75 by 75. Then maybe after 6 months or so, you can knock off one more. Because the patient, as per most guidelines, needs to be only on one antiplatelet agent after 1 year, after stroke or after an MI. So that is one area which you can do. Another area where you can reduce polypharmacy is misuse of proton pump inhibitors. Chronic pantoprazole intake. That has got problems of its own. B12 deficiency, chlorhydria, dependence on PPI, all those things. That you can reduce by reducing the dose of, say, pantoprazole the patient has been taking for a long time. Convince the patient that you don't really need to be on this drug for all the time, especially if you don't have symptoms. Let's try making it 20 mg per day. Then make it 20 mg alternate day. Maybe you can give ranitidine 150 mg at night to cover up for nocturnal acid suppression. If the patient is happy on this regimen, then stop the pantoprazole in the morning and make it Rantac 150, ranitidine 150 twice a day. Then keep it only in the night. Because most people, the stomach is empty at night, the acid might give them some symptoms. If reflux is the problem, add a domperidone to the night dose of ranitidine. So there is Rantac dom for that. And keep only ranitidine at one time in the day. If that is also tolerable, stop it altogether and give him SOS antacid. Keeping in mind other drug interactions like antacid, like iron tablet, calcium tablet, etc. That's all. So you can, over time, in the same sitting, you can reduce a few medicines, but over time, you are able to minimize a lot of overlapping prescriptions. Okay, but beyond a limit, it might not be reasonable because, for example, in this patient, you can't stop the oral antidiabetic drug. Then you can't stop, say, thyroid medicine. You can't stop the statin or the aspirin. So there's a bottom line beyond which you can't go. Okay. So someone was commenting something. I missed that actually. Yeah, I think someone mentioned benzodiazepine before I got my connection got cut off for a second. Benzodiazepine is also one area where you can think of anything which you feel the patient is not on absolute need. Always think of cutting short that drug from the. Okay, any further questions? Okay, use of ARNI in heart failure patients. Okay, I think that's a good question. So for that, you need to know heart failure with preserved ejection fraction, reduced ejection fraction, and improved ejection fraction, etc. So in reduced or improved ejection fraction, you can consider that class of drugs. That decision is actually taken by the cardiologist, depending on the previous cardiac status, current ejection fraction, and maybe a NT-proBNP also, if the report is available in the facility. If the patient is at high risk of heart failure, yes, ARNI has to be considered. Yes.
Any further doubts from the PGs?
So thank you all for the patience.
So, shall we wind up the session, sir? I think there is no further doubts from the students.
So this was an
I hope
excellent.
you have got some take-home points and messages which you can apply in your practice from tomorrow morning onwards. I hope you found this useful.
Yeah, thank you, sir. Let me welcome Dr. Jai Ganesh from 360 Coordinator to for vote of thanks.
Good evening all. So on behalf of Spice Road Kerala chapter, I extend my heartfelt gratitude to Dr. Vijay sir for the insightful and engaging discussion. We are truly thankful for the valuable perspectives you shared, sir, for spending your time with our students. And I would also like to express my sincere appreciation to Dr. Hirash for the wonderful presentation. And lastly, my warm thanks to each one of you who joined this evening session. Thank you all once again. Good night.
Good
Good night. Thank you.
night.